augmentation, artificial bone remodeling, bone manipulations, biomaterials, growth factors, and many, many different terms. So I can say that this is not dentistry of our fathers. This sentence is not mine. I only this sentence in one interesting surgical book, but I think this is in the center of our contemporary problems with these augmentations. What we should think about this new approach to dentistry. The art of practitioner is to correctly classify the amount of innovations and information for the benefit of the patient. What is good and what is bad for our patient, what is risky and what is predictable, what is effective and what is unnecessary, and what pays off and what only costs. What is fashionable and what is enduring. The basis of judgments is experience and profound knowledge. In the first place, I try with this theoretical part of lecture to explain what is aim of this different approach in the dentistry. In the first place, do we understand the true nature of augmentation materials? Then can one material provide everything we need for successful augmentation? Can you just insert the material into the tissue and wait for the good results? Or what actually happened in the tissue after the application of augmentation materials? I think the last one, it is a most important question for us. What was changed because of these augmentation materials? Dentistry is going from outside to inside. With this change, we should think about structure, which are not prosthetic, which are not tools, but root fillings, and etc. We should think about this other region. To implantology, among other things, the spectrum of dental treatment has expanded into inferior of our bodies, and implants were just the beginning of this change that is now happening in maxillofacial surgery, plastic surgery, ENT surgery, and so on. This requires better and broader theoretical basis for dentistry, which is derived from biology and medicine. Many patients and dentists today are no longer satisfied only with osseointegration of an implant at any position for the mere fixation of overdenture. The implant is expected to be placed in ideal functional and aesthetic position. So when the implantology starts, we had so-called surgical-driven approach to treat patients with implants. But now, if you look in some cases, Dr. Serkan mentioned that if you put implants only in position that you have the bone, we can make problem for prosthetic and to have such situation. Or something like this, because the implant is also integrated, but is too buccally oriented. So, again, we can have good also integration of implants, but bad positions of them. This is the biggest problem for our prosthetics. So during the time, this approach, surgically driven approach, was abandoned, and nowadays we have prosthetically driven approach. So me as a surgeon have to speak and to get some advices from my prosthetics in which position to put the implants, what is best for the final result. But why is that? How this became very important, this prosthetical driven approach. So if we want to succeed surgically and prosthetically, we should to follow some rules, which are rule of 6, 3 rules, Cunningham rules, and we have some other rules, but I will start with this one. So we call this prosthetically driven approaches. What means rule of 6? So we need to have 6 millimeters of interradicular space. We need to have 6 millimeters of buccolingual osseous dimension, 6 millimeters of minimum implant length, 6 millimeters of interocclusal distance for prosthetic and component requirements, and less than 6 millimeter distance from the bone crest to the interproximal contact point for papillary formation. What are 3.32 rules? We need to have to put implant in ideal position and to have this distance from the zenith to palatal position and 2 millimeters in apical position. If you want to reach ideal aesthetic result. For the lateral part, we have this Cunningham first molar rule, which introduced by Mish, and plus we have to have other rules regarding type of implant, length of implant, and which type of implant we are using in which region. Their position also is very important. But what we can do when we have not bone or we have this kind of resorption, if you put implants in surgical way, in this position, where is the bone, there will be no occlusion. If we want to put implants in this position, we need to do something with resorbed bone, or we need to do augmentation. So this surgically driven approach can be changed in prosthetical approach and nowadays in regeneratively driven approach. As you can see on this slide, for atrophied edentulous maxilla, prosthetic approach, we need dental implants only as an anchor for the prosthesis. In the regenerative approach, we need ridge augmentation, sinus lift as a dental implant as tooth root replacement to initiate masticatory forces for the bone. The replacement of missing body parts with a prosthesis in the conventional procedure in many medical fields. The regenerative approach of augmentation is seen as a future in the dentistry. bone augmentation, therefore, in principle is a functional-based medical rehabilitation. Implantology has masticatorial rehabilitation as its primary medical goal. With good function, good aesthetic often results automatically. In addition, aesthetics is becoming more important as a therapeutic goal. In this replacement, this regenerative replacement, the primary function of the implants is as tool for the introduction of masticatory forces in the jaw. Only introduced masticatory forces initiate the functional remodeling of the tissue, which ensures their lifelong preservation. In the body, only what is functional is defined as preserved. So, because we are going from outside and inside, we should change our way of thinking. Why that's so important? The hard tissue of the bone is a composite material, consists of fibers and fillers, with the fibers absorbing tensile loads and the filler absorbing compressive loads. The stability of bone is determined its internal structure. This internal structure results from derivation of the collagen fibers, which, like wires, provide internal tensile strength to the bone. There are many examples of such composites in engineering: reinforced concrete or glass fiber reinforced plastic in the boat building. And do you know from which material made this bridge? Here in Vietnam, from fiberglass. It looks like concrete, but made from mesh of fiberglass. So when we want to make some changes in our ridge, we became, in one way of thinking, bone engineers. We are not anymore only dentists, we are becoming bone engineers. Because we want to replace the bone, to rise again, to stop this reduction of the bone and the resorption of the bone. So we need to think about alveolar ridge as a structure. Biological structure. So use almost same principles, same terms, which are used in building construction. So you have site preparation, the foundation, framing, roof siding, interior and exterior of this building construction. So our ridge is also some kind of building reconstruction. So we need to analyze what kind of material we are dealing, what are behavior in the organism of that materials, how many time we need to get final results, what are the methods of application of these materials, and do we have some specific anatomical locations when we want to use these augmentations and bone and soft tissue manipulations. They are closely each to other, and we can treat them separately, I think. We can split this bone manipulation in two ways, in two approaches. in preventive and reconstructive approach. Under preventive approach, I mean on the first place, I said to my student, the first step in good implantology is automatic tooth removal. As Dr. Serhat already says in the previous lecture. Then, an evaluation of remaining walls of the bone following the extraction and evaluation of the size of the defect. Complete removal of granulation tissue is the next step, and we have to ensure adequate supply to the graft site. We should choose appropriate graft material, graft containment and soft tissue closure, and ensuring adequate time for healing. So, when we have such gentle tooth extraction, we can easily treat this wound with augmentation material and to get excellent results. We can use different kinds of materials for this augmentation. In dentistry, but in the orofacial region, we can use this material for different indications. On the first place, those are periodontal defects, periimplant defects, extraction of defect following root extraction. Doesn't matter, does damage buccal plate. If we have large defects, as the tooth root apex, resulting from pulpal infection or failed root canal procedure, resorbed or atrophic alveolar ridges, tumor resection or trauma resulting in osseous defects, and developmental abnormalities. So you can see that is a large number of indications for using augmentation materials. But how to choose the right material? In Botis portfolio, we have a large number of different kinds of material for hard tissue or soft tissue augmentations. And what is a protocol for succeed if we, or when we use these materials? On the first place, we have to understand that these materials are not real bone, and in my country they says artificial bone. Those materials are not bone in any way, natural or artificial. They are just replacement, and we want, with using these granules and materials, to make space and scaffold maintenance. Then we need stabilization of the cloth. Dr. Serhat also mentioned that. So we need to make these materials to be sticky, to be moldable, and to stay on the defect, not to be movable. Why this is so important, I will explain you later. Then we want to do this modification of cellular activity because our patients are always asking us how long we will treat them and when they can get the implants, etc. So we want to get as much as faster healing if it is possible. And of course, when we have augmentation material inside the wound or or inside of defect in the bone, we need wound isolation in the manner to stop granulation tissue to enter inside of this bony defect. Basically, we have two types of these augmentation materials. We can divide them in natural transplants and synthetic materials. And natural transplants are autografts, allografts, and xenografts. And synthetic materials, we call them alloplasts. What is a major difference between them? Autografts are tissue transport from the same individual from one place to another. Allografts are transplant taken from the other human donors. Grafts taken from different kind of donor are xenografts, and alloplastic grafts are synthetic or implant or inert implants. What is important to know, what is important difference regarding this kind of material is that it could be short period of augmentation, they could be medium period of augmentation, and they have long period of augmentation. Materials of short period of augmentation are autografts, allografts, and they last in the bony defect between 3 and 6 months. Due to more rapid turnover of these materials, they should be selected when implant placement will be done in 3 or 6 months before significant ridge resorption take place. Materials of medium period of augmentation are granules obtained from alloplastic grafts like calcium phosphate, calcium sulfate, composite polymers, and ceramics. Material of long period of augmentation is solid hydroxyapatite, but this is not using in everyday practice. So now I want to analyze all 4 steps of bone augmentation and soft tissue augmentation, and what are basic characteristics of these materials. Space and scaffolding maintenance. Why we need this? Because bone can grow into the empty space. So we need to fill this bony defect with granules. When I start with dealing with these augmentations, first material was like powder. But with this kind of material, it was impossible to get proper vascular vein growth. So then companies started to make this material in form of granules. So we need to fill the empty space with granules. What are prerequisites for undisturbed bone healing? These bone substitutes act as artificial bone matrix, a scaffold for the existing osteoblasts. You know that osteoblasts are the cells that form new bones. Osteoconduction refers to the formation of the new bone tissue, a position growth from the walls and graft recipient side. So we can get new bone on from the walls, but we need something between these walls to get new bony cells. So because of that, we need mechanical stability. Just the first important basic prerequisite for the bone healing, along with the coagulum, a phenomenon that is well known from fracture treatment. What is another characteristics of these granular materials? Mechanical stimulation. Biomechanical stimulation. Grafting of extraction sites provides physiologic and bioelectric stimulation of adjacent bone via attachment and local transmission during normal jaw function. Random orientation of particulate graft could transmit this loop from particle to particle and from particle to the bone in a manner similar to the periodontal apparatus of natural tooth. So, after we fulfill this empty space, we are reaching this biomechanical stimulation. As you can see, when you put these granules inside, they can push each other and to transfer this and to make this biomechanical stimulation on the bony walls. This healing, besides the pain, because neoangiogenesis can usually breach 2 millimeters in the tissue. Soft tissue wounds therefore reduce larger distance with scar shrinking, which bone cannot. Bone regeneration may only include the basal particles of the bone substitute material. Angiogenesis at alveolar ridge does not penetrate further than 3 to 4 millimeters into foreign material. A meta-analysis of all relevant published results on alveolar ridge augmentation revealed a maximum horizontal and vertical building height of 3.7 millimeters for particulate materials. So we can put inside many granules, but there will be no results. Only we can get only 3.7 millimeters of the new bone. The potency of neoangiogenesis of the jaw is only sufficient to vascularize about 3.7 millimeters of overlying bone substitute. As you can see in this meta-analysis from torture, you can see if you need horizontal and vertical augmentation with particulate materials, you can get only 3.7. If you need more, you must use bone block. Doesn't matter from which region, from mandible or hip. So these granules are not magic materials, they have their limitation. So surgeons need to focus on two things: new angiogenesis and wound stabilization. Without wound stabilization, we will not have any kind of a new bone. What we need for this stabilization, we need something to stick together all those particles, all those granules. And what we have to do is fibrin, because the fibrin is the first healing matrix in the injured tissue. Where we can find this fibrin, of course, we can find in the platelet-rich fibrin, which is an immune and platelet concentrate collected on single fibrin membrane, all the constituents of a blood sample fiber for healing and immunity. Fibrin is the natural guide to angiogenesis. is some kind of reinforcement for the tissue healing, like Red Bull for tissue. The initial concept of PRF is based on biological event starting after injury, and after injury a fibrin and platelet clots are formed. Clot formation initiates healing mechanism. So before introducing this PRF in the wound and mixing with the granules, we will not have this healing potential. What we can use also to get these granules to be sticky, to be moldable, and what is important for the surgery, we can easily handle with these granules. When I started to do these augmentations long time ago, I have at that moment crazy idea to use ginger as a sticky environment. And my idea was to, if you can use ginger to treat gingiva from outside, I can treat gingiva also from inner side. So, this hyaluronic acid has been applied as a primary biomaterial for temporary soft tissue augmentation and as a carrier for cells and delivery of growth factors to promote tissue regeneration. In 2010, I published this article. I had a young guy, 9 years old guy, with big cyst in his mandible. So when I started to analyze this case, and I started with this surgery, I noticed that those tooth are firmly fixed for the lingual plate of the bone. So I decided to not remove them. I was very careful to remove this cyst, but to spare this tooth to stay on the place in the bone. I told you in that moment such material like PRF doesn't exist. So my idea was to use this ginger to mix these granules. In that moment I used this LTR 3-calcium phosphate for fulfilling this kind of defects, but I never tried to treat such a big defect like this one. And the final result after a few months was full recovering of the and the new bone. And as you can see, this tooth was erupted, and it is vital. Only with hyaluronic acid and 3-calcium phosphate combination used. I never seen this guy after this operation, but I'm very proud that I could spare the tooth for him. So this was my thinking in the beginning of the using of this material for bone augmentations, because in such case I had to remove those these tooths to do marsupialization or some classic surgical approach to manage this cyst, but I decided to try something different. Nowadays, we have already prepared. Dr. Serhat show this preparation of Cerebon plus material. I think if you don't have opportunity to take blood from the patient and to make PRF, this could be good solution, fast solution if you want to do some augmentations of the bone, especially if you want to put after tooth extraction in order to get some allo preservation. As you can see, this kind of material is very sticky and ensure to us that we will, if we put this material inside of defect or in alveolus, very shortly we will have new angiogenesis, and that these new vessels are without disturbing and without destroying of new vessel. So after that, after we fulfill this bony defect and make it these granules to be sticky, we need to make this wound isolation. We want to isolate this wound from the outer space, from the oral space, and we need this isolation by means of occlusive membrane, and this isolation has been demonstrated to prevent invagination of soft tissue, very aggressive oral epithelium in the healing socket, favoring the repopulation of the socket with cells, with bone regenerating potential and leading to more complete bone field. We have big portfolio from the Botics company or from this membrane. And when we speak about membrane, we always speak about this isolation and to be some barrier for the granulation tissue, regrowth. But these membranes have another influence on the tissue. Isolation of the underlying tissue may also concentrate growth factors on cellular elements necessary for healing. Presence of bioactive framework or scaffold allows bone formation to be distributed more efficiently within the given space and extraction site of the parts of alveolar region. In particular, anorganic bovine bone has been shown to support osteoblastic cell attachment and proliferation. Thus, the combination of membrane isolation as an osteoconductive implant material facilitate complete bone field in a bone defect. What are additional advantages of collagen membranes? On the first place, they are hemostasis. They have hemostatic influence on our tissue. Hemotaxis for periodontal ligament, fibroblast, and gingival fibroblasts. They have weak immunogenicity. They have easy manipulation and adaptation, direct effect on bone formation, and ability to augment soft tissue thickness. Dr. Serhat already mentioned how is it important to have proper tissue thickness. because resorption of bone grafts is always bust. Osteoclast, these cells should be inhibited to minimize this surface resorption. Because osteoclasts originate from glustery progenitor cells, a membrane should separate them from blood vessels of the covering soft tissue flap and from the bone graft surface, thus blocking the pathway for the osteoclast. So not only to block granulation tissue, we want to block also osteoclast to not resorb these granules of the remaining body walls. Then, with using of this membrane, we want to buy time. Why this is important? Because we have different healing time between aggressive granulation tissue and between the bone. As you can see in the slide, we can see that epithelium grows from 0.5 to 1 millimeters daily, which is big difference with the bone, which is grow 1.5 millimeters per month. Because of that, we need to have good membrane to isolate this soft tissue and to buy some time for the new bone formation. Buccoperistal flap acts by fibrin clot in first 24 hours. And this is one of the requisites to have good bone healing. After 1 week, clot is replaced by granulation tissue, and in 2 weeks, the flap will be attached to the bone via immature collagen fibers. So we have everything in one membrane, what we need to have proper healing. So this is some kind of race, slow race, but we have different kind of tissue. We can call this race tissue against tissue. We always looking for some fast solution, but in this augmentation is not possible to get result very fast for the short time. So we need some kind of acceleration of healing. As I already mentioned, on the first place, this is a PRF plugs, which have growth factors on the one plug. We have different materials for healing acceleration. On the first place, we have purification from human tissue, BMP, then we can use fibrin glue as a gel or sealant. We have recombinant factors, BMP2, PDGF, autologous platelet gel, PRP, PRGF, but for us, the most important source of growth factor is PRF. So what we want to get with these growth factors, we need modification of cellular activity. The implantation of this bioactive substance evokes cellular response from the adjacent tissue. So we need this acceleration from every side, from the bone, from the mucosis, from every kind of cells that can regenerate this part of our ridge which was destroyed and which defect we want to close. So we need growth factors. because of that, the best solution for us is to use this PRF. What are general factors for this correct bone healing that they are influencing on our treatment? On the first place, this is intactness of periosteum in covering flap, surrounded depth bed, and do our patients have smoking habits, or sometimes they can have a lack of vitamin D and vitamin C. Dr. Sekel also mentioned this group of patients smoking habits, patients with smoking habits, which can compromise our success, but we should treat and those guys also. I can exclude these patients because of their habits. I ask them to treat their tooth better, if they can, to quit smoking, but I have to treat them as all other patients. What is a reason for impaired wound healing and wound dehiscence? On the first place, poor wound preparation technique. I started with this complaint of my colleagues, and I think the major reason is a lack of surgical technique. And then, many reasons for misunderstanding for what these materials are capable for. So there is no magic material. There is no magic material, but we should know what are the major characteristics of this material, grafts, growth membranes, and how to use it on the proper way. Dr. Serhat says if you didn't stitch this flap on the proper way, you will lose this material, membrane, granules, and everything, because you will have primary infection. This is not a problem with materials, but with communication with dirty tools and dirty environments. Also, Dr. Serhat mentioned needs for this flap mobilization. If you didn't done proper flap mobilization, you will have flap tension. And next problem is necrosis of these edges of this flap. So again, this is not problem with materials. It is problem with your surgical technique. Granules between the edges of the wound. Sometimes we are in a hurry, so sometimes we don't do things in proper way, and we left some granules between the edges of the wound. Normally, they will stop angiogenesis between the edges, and we will have dehiscence in that region. I show in those complications on the beginning, one guy with permanent membrane. This is my patient. I make that mistake. I left few granules between flap edges. So after 1 month, I had this wound dehiscence with visible permanent membrane. And then too tight sutures or stitches that are too dense. We have to think about these microscopical events. If your stitches are too tight, there will be no blood supply. And we need blood supply of course, or if the teachers are not stable, so as a result, the tissue of the wound margin loses stability and vitality, looks irritated and becomes tender and mechanically unstable. In this slide, you can see how it looks wound, clear wound with good adaptation of intact membrane, and we have sterile granules inside. On the other slide, you can see the bed stitching of the wound edges, flat edges, and situation that we have wound infection. So the major problem today is this biofilm formation when we have this dehiscence in the wound. So when we think about good result, we have to think about another race. And this race is tissue against bacteria. In the first place, the goal of suturing is therefore a microscopically firm adaptation of this mucosal flap and well perfused valve margins. Once the suture has been overcome by bacteria, it's necessary to go there further access, and this is done intraoperatively by inserting barrier membrane. So this is another influence of this barrier membrane. Collagen membranes block the path of the bacteria from some time until they have been digested by bacterial enzymes, and this takes only hours if this membrane is visible or exposed to the oral environment. Placing other soft materials, PRF membranes and collagen fleece, for example, beneath the collagen membrane is also beneficial because these materials are hydrophilic and form a type of gel that does not build up and interface with the body fluid. So we need to have two-layer covering of soft tissue, flaps that are thick as possible, soft tissue augmentation, we call that. Also extend to distance that bacteria must travel. So we want to make problem to bacteria. There are clinical examples of all these methods. It's also very effective to prevent bacteria from growing into the first place by limiting solid liquid interfaces. The channels between the threads are sutured a weak point. Because of that, it's very important which kind of suture is using and what is our surgical routine. One should find a good clinical compromise between creating a bridge for bacteria and keeping the wound edges together. In normal intraoral surgery, this means suture removal after 7 days, augmentation surgery. In augmentation surgery, we need more time, which is about 10 to 14 days. But this biofilm is so important because it's a triggering factor for impaired wound healing. So if we done everything good, but if we have biofilm inside of a wound, we will suffer a lot together with our patients. So biofilm-related infections are therefore problematic because the biofilm protects bacteria from antibiotics, both mechanically and through biologic resistance mechanism. So if we have biofilm, antibiotics would be useless. In the jaw and in intraoral surgery, most infections of low dehiscence in augmentation surgery occurs clinically 4 to 10 days postoperatively. Because bacteria first need a certain amount of time to build up this biofilm. As soon as the bacteria in the wound encounter hard material and thus interface from solid to liquid, they can adhere and begin to build up the biofilm. Such biofilms always form at solid-liquid interfaces. These solid-liquid interfaces allow bacteria to grow and are resistant by polytetrafluoroethylene or PTF membrane, produce more dehiscence compared to soft collagen materials. So, again, in some kind of conclusion for this first part of lecture, there is no magic material. We have to know all characteristics and what we want to reach with our surgery.